Every child has unique needs when it comes to their health. Thankfully, St. Luke's offers personalized treatments designed with children in mind. Today, we'll talk with pediatric specialists about the care available at St. Luke's. I'm Ashley Russo, and this is St. Luke's Health Now. Coming up on this episode of Health Now, an in-depth look at pediatric specialties offered at St. Luke's University Health Network. Stay tuned. Thanks for joining us. Our first panelist tonight is pediatric surgeon Dr. Rajiv Prasad. He performs general, thoracic, and minimally invasive surgical procedures. His practice is solely dedicated to the surgical care of infants, children, and adolescents. Dr. Prasad brings over 20 years of experience to St. Luke's Children's Hospital. Thank you so much for being here.
Thanks for having me.
Tell me a little bit about your interest in pediatrics and specifically pediatric surgery.
Like all pediatric surgeons, I started with training in general surgery. But to become a pediatric surgeon, one has to do further training. So I did a fellowship in pediatric surgery. And that has allowed me to focus during my career solely on the surgical care of children.
And how does that vary from going into pediatrics in general, where you might see children for their well visit, versus when you're seeing them for a surgical procedure?
So we are a consultant service. So we rely on the primary care physicians to identify problems and refer them to me. That could be in the office setting for something that's completely elective, or it could be in the hospital setting if a child's admitted to the hospital and some ailment requires a consultation with me.
People think little people, children are little people, but they often have unique anatomies and complex organ systems. How does that training come into play when you're looking at studying specifically to work on children?
Well, we actually have a saying that children are not just small adults. So this is why we go through the training and throughout my practice of over 20 years honing skills in children. So yes, they are smaller, of course, but we have to take care not just with the smaller patient, but with more delicate tissue. And also there are many conditions that occur just in children that you won't see in an adult. And that's the reason we go through this training, so that we are equipped to deal with those.
Joining our panel next is pediatric gastroenterologist Dr. David Blanco, whose practice is dedicated to the diagnosis and treatment of children with diseases of the gastrointestinal tract and liver. He has a special interest in nutrition, celiac disease, and inflammatory bowel disease, and he cares for newborns through young adults. Dr. Blanco, thank you for being here.
Thank you for having me.
Tell me a little bit about your interest in this field and how you subspecialize as a gastroenterologist for pediatrics.
So pediatric gastroenterology differs from surgery is that we're primary pediatrics. So we have to go through a pediatric residency for 3 years and then follow that up with a pediatric fellowship in pediatric gastroenterology. So my interest really came from just kind of looking at the patient in multiple different ways. So just seeing them in the clinic, via endoscopy, looking at their slides from endoscopy, looking at them in radiology, and I'm more of a proceduralist. So, I'm very interested in kind of helping them in diagnosing.
And from the time, a child is born, sometimes you hear about things like reflux or they have got, colicky baby. How does your specialty extend from that newborn stage all the way up to the adolescent stage?
So we are entrenched as soon as they come out. So from newborn all the way to early adulthood. So we're definitely specializing in those babies with reflux, with vomiting, with difficulty feeding, difficulty gaining weight. All these things we see in our clinic and assist day to day.
We're looking forward to learning more. Thank you both for being here. We'll be right back after a short break. But before we do that, let's check in with Dr. Dustin Greenhill out in the field as he discusses pediatric orthopedic care.
Hi, I'm Dustin Greenhill. I'm a pediatric orthopedic surgeon for St. Luke's University Health Network. We have a full service line of pediatric capabilities at St. Luke's University Health Network. Our pediatric orthopedic surgeons cover all 14 plus hospitals in the network. I'm also the Associate Program Director of the Orthopedic Surgery Residency. So all orthopedic surgeons that you'll meet are trained similarly throughout medical school or orthopedic surgery residency. After that, people can subspecialize within the field of orthopedic surgery. So A pediatric orthopedic surgeon does specific training in that. And even within pediatric orthopedic surgery, we tend to subspecialize. For example, I do a lot of trauma and scoliosis and limb deformity. Unfortunately for kids, the most common conditions are the ones that hurt the most and the ones that are the easiest, to be honest, for us to treat. They're fractures. So a child, no matter what age, falls off the monkey bars or falls in sports, has a broken bone. Almost 90+% of the time, those can be treated without surgery. Obviously, we're surgeons, but the 10% of the time, you need it to be done right, especially when it's around growth plates and things like that. So children are not more prone to sustaining injuries per se, but they can be daredevils sometimes. So I like to say when kids get injured, they're doing exactly what they were supposed to do. They were having fun usually. If a child gets injured, we treat them differently because their bones are different, the structures around their bones are a little different, the growth plates are in certain plates of their bones, and the tendons and ligaments that attach in certain places that makes their bones break differently. And therefore, a pediatric orthopedic surgeon is trained to fix those injuries differently. By far, the most common operative fracture is an elbow fracture. It's called the supracondylar humerus fracture. It's usually around 6 years old, but it can be anywhere from 2 years old to the lower teens, and they usually fall, most often off monkey bars. The elbow and where they break is very important for the future function of their elbow. They heal so fast that we almost always are able to fix it without an incision. So most cases of scoliosis do not require surgery. There's a plethora of different reasons that a child can have scoliosis. The most common one is something called idiopathic, which basically means you have a crooked spine, but nothing else is wrong. It is almost always not operative. The majority of patients do not need surgery, and the majority of patients diagnosed with scoliosis, to be honest, don't even need treatment. The important things about scoliosis is at a young age, it can progress very quickly. And if it progresses to a certain point, it could be a lifelong problem. If you fix scoliosis in a child that needs it fixed when it's appropriate, you can basically eradicate that from being a concern for them for the rest of their lives. A limb abnormality in a child could be anything from a crooked foot called club foot. You can be born with a dislocated hip called developmental dysplasia of the hip. We have patients, all varieties of deformities. We have patients come in with extra fingers, not enough fingers, a short leg, a crooked leg, all these conditions. Sometimes it goes along with a syndrome or a chromosomal abnormality. So this is a very niche region of pediatric orthopedic surgery that really, we're the ones that know about this stuff. Parents should choose St. Luke's Children's Hospital because everything you need for your child is available here. This is one of the only places in the region where you're going to get multiple people who are fellowship trained in pediatric orthopedic surgery. We work as a full department of orthopedic surgeons. We cover multiple hospitals. We can do everything here. I think the best thing about what we do is you meet a child and you meet a family in a moment where they really need guidance and they really need clarity, and sometimes if they're a big broken bone, they really need help. And following them through that, and sometimes very quickly, you get to see them in a very different light. They see you as a person, and you just help that kid get back to being a kid.
I would recommend the St. Luke's School of Nursing to anyone that was pursuing their degree in nursing.
When students come to St. Luke's School of Nursing, you can expect a holistic approach.
Making a program that is dynamic and diverse and evolves with time is very important to us.
We not only see the moment, but we also prepare you for the future.
When I hire the School of Nursing graduates, I know I'm getting a quality nurse.
They're here to teach you everything you need to know to care for these patients effectively.
Kids have enough to worry about, like tea parties, problem solving, and, well, growing up. So let us worry about their health. St. Luke's Pediatrics.
Welcome back to St. Luke's HealthNow. Tonight we're discussing specialties in pediatric care and the many advances offered at St. Luke's. We want to thank you, our viewers, for tuning into our program and for submitting personal questions that we'll answer later in the show. Joining me are Dr. Rajiv Prasad and Dr. David Blanco, who are experts in a variety of pediatric specialties. Let's dive deeper into the services offered at St. Luke's. Dr. Blanco, I'm going to start with you. What are some reasons, and I know this is a big question, but what are some reasons that parents would come to see you for a GI issue with their child, and how do they know that they need to see a specialist?
So I think many times we partner with their primary care physician, and they're very good in kind of providing that referral and guidance. It's difficult to say when it is appropriate. I always feel that if the parents are really concerned, then that's the appropriate time. So in terms of, what we can provide, it's a number of services. But for the most part, I feel that, the baby who vomits is not unusual, especially because of the reflux, and there's reflux disease, which again are not synonymous. There are many episodes of vomiting, or there's a certain amount of vomiting within that newborn period. But when it starts to really kind of affect their growth and, whether or not they like or enjoy feeding, that's when it becomes an issue.
What about the older stages? School-age child, middle school, adolescence, especially as a first-time parent, each stage is new. How do you know what requires further care?
That's a great question, because I think especially during the first couple of years of life, there's this tremendous amount of growth in, just eating in general that happens. And around like kind of late toddlerhood and early elementary school age is that they kind of cut down in terms of what they're eating. But as long as they're following their curve in terms of, where their growth is, and we take, their growth very, very seriously. Because many times that can be kind of a tip-off where there's something else that may be happening with the patient.
Always tough to know the balance, but better to get help than ignore it. Dr. Prasad, what about you? What are some common things that you're seeing children that have surgical needs that parents are coming to you, and how involved are they in the process?
One of the most common things that I'll see on an elective basis, for example, is hernias. There are different types of hernias in children. Almost all of them you're actually born with. These conditions may or may not require surgery right away. On a more urgent basis, one of the very common things that I deal with is appendicitis. Some parents are surprised that their child has appendicitis, but it's actually quite common, something that I deal with at least a couple of times a week. Beyond that, some of the less common things, but things that are seen and need to be treated by a pediatric surgeon, include congenital anomalies in babies, problems with the esophagus, the diaphragm, intestinal blockages, some of which require surgery within the first couple of hours of life. The parents are always involved, need to be involved. It's their child, their baby undergoing surgery. It's very important for me to keep them involved and keep them informed every step of the way. They naturally have a lot of anxiety. Their child needs surgery, something that shocks them. They have to undergo anesthesia. So it's an important part of my job to take care of the family and the parents as well as the child.
Absolutely. And I would imagine that, Dr. Blanco, you're also dealing with parents in a very troubling time. They're concerned and may not know what's wrong. What are some of the common conditions that you are seeing in children, and how are those diagnosed?
Many of these conditions are diagnosed just via history physical examination. For the most part, children are relatively healthy, and what they're usually coming in with what we call functional issues, or functional pain, or functional constipation. So constipation, abdominal pain, vomiting, nausea, these are things that we see on the day-to-day basis. But we're also screening for certain diseases like celiac disease, inflammatory bowel disease, multiple food allergies. So, every time we see a new patient, obviously, we're speaking to the parents for the majority of the visit. It doesn't take very long, and it's really used to kind of confirm what we're already thinking. We do have laboratory tests that we can do to kind of help narrow down the diagnoses that we're considering. And ultimately, I think if it's very concerning, if we think that it would be helpful, we can diagnose with upper endoscopy and colonoscopy.
And those types of procedures, I would imagine, also elicit some fear and concern in parents because that's more advanced testing. How do you, reassure them that this is an important part of the diagnosis and the process?
It's always a balancing act because, I feel that for the most part, parents are a lot more concerned about their children than they are for themselves. So whereas every person should be going under a screening colonoscopy at 45, to have your daughter have a colonoscopy at 2 is very concerning. So we go through the process, and I tell them, I'm not a surgeon. This is not surgery. This is a procedure. So, and I also make them aware is that, their child isn't going to feel any pain. And ultimately, it's to make a diagnosis and get answers.
Which is so important. And Dr. Prasad, how important is the multidisciplinary approach at St. Luke's? And how closely do you work with Dr. Blanco and with the variety of pediatricians and pediatric specialists, especially when it comes to surgery?
We have important and really collegial relationships with other specialties. A child may come in with a vague complaint, for example, that requires investigation, not only by me, but by other specialists. That could include pulmonology, endocrinology, and of course, gastroenterology. Dr. Blanco and I and his team we all work together pretty closely and have for a long time. There are many conditions in children that require both a surgeon and a gastroenterologist. We discuss them. Some need a procedure by Dr. Blanco, some need surgery, others need medical management. But that interaction is very important quite frequently to get to the bottom of things.
When you're looking at the diagnosis point, Dr. Blanco, what role does nutrition play? It's very hard. People do worry a lot about what their children consume, but of course, they want that snack. It's tough to avoid it. So what role does that play, and how do you counsel patients around that?
So I think a lot of the conditions that we treat can be treated via nutrition. And many times we use medication as a bridge, kind of treat the issue at hand, and then ultimately kind of use that to transition to kind of changing their diet. For the most part, I feel that, diet is really critical for our patients in treating a number of diseases. For example, like celiac disease, the treatment is diet exclusively. You cannot consume any gluten. And there are certain other conditions like Crohn's disease where diet does play a role, sometimes exclusively as diet, but all other times it's almost an adjunctive therapy. So in addition to medical management, we do know that it does improve the prognosis. But because we're in pediatrics, we're always concerned about the growth and development of our patients. And I always speak to parents on talking about their true genetic potential. We want them to meet their true genetic potential. So meaning that if they were destined to be 5'4", we want to make sure they're going to reach that height of 5'4".
That balance between eating healthy and doing what's right for your body, but also managing the growth of a child.
Right. I mean, in moderation, everybody
expectations, exactly. Well, Dr. Prasad, speaking of managing expectations, what can parents expect when they find out that their child needs surgery and the whole process that they'll go through with you and your team?
The parents are involved from the beginning to the end. For example, an office consultation, our office is set up to be very child-friendly. We have toys, we have things on the wall for the children to play with. The parents are, of course, with them. I have to gauge a child's maturity to see how much I'm going to have them involved. Once they're in the hospital, the pediatrics floor is brand new, very child-friendly, with great space in the rooms for the parents to stay so they don't have to leave their child in the hospital ever. We have a new PICU, pediatric ICU, with pediatric intensivists and nurses. So the whole operation is set up and geared for a whole family, not just the child. Specifically, pre and post-op, it's very important for the parents to have their expectations set, but then also met. During the process, they're involved with child in the hospital if they have to stay. And then post-operatively, it's important for the parents to be involved, to relate to me the child's condition, for then me to be able to determine when, for example, they can get back to regular activities.
Because so much of the communication, as you mentioned, is reliant on the parents and the parents being proactive in that conversation with you. How important is that to what you're doing? And when parents come to see you, what do you want them to know about that communication and the information that they give you?
We want to really keep communication open. And I think in terms of with our interaction, we make sure that they're educated, they know why we're doing certain things. Really, that also helps compliance. And just what Dr. Prasad was saying, is just to really kind of set expectations and to meet them. And there are certain times we'll say, well, we're going to move forward with this procedure. This is what we expect. And, sometimes it's not therapeutic. That's not to treat anything, it's really to make a diagnosis.
If there is something that needs attention, it's great to know that you and the team at St. Luke's Pediatrics are there for them. These services are available right within our community. All right, we have some questions that our audience sent in. We'll get to those right after the break. Stay tuned.
Hi, my name is Kylie. I have Crohn's disease and I received my treatment at St. Luke's. When I was 11, I started getting this excruciating pain in my stomach. Every single time I'd eat, I'd either throw it back up or I'd be in intense pain for the rest of the night. Nothing would help. The thing about Crohn's disease, it's an invisible disability. People can't really see it. It can feel very lonely being a child with Crohn's disease, but there is help out there.
Kylie was 11 years old when I first met her. One of their blood work studies was very elevated for inflammation. Upon further investigation with endoscopy and colonoscopy, we found that she actually had Crohn's disease of the large bowel and small bowel. IV infusion medication, specifically the one that she was on, was called infliximab. And so that is a biologic medication, so it's synthetically made. And the idea is that these medications are found to be actually safer and have better results in terms of obtaining what we look for, clinical remission and histological remission, meaning that these patients get better and their cells turn over to normal. We saw a significant improvement with the first infusion. She kind of just did a 180.
When I was getting the infusions every 8 to 6 weeks, I definitely missed out on a lot as a kid. So there was a lot of times growing up I couldn't keep up with my friends, and it was frustrating. But being in remission's given me everything back. I was always too tired to do anything, and now I get to go get my education, I get to be with my friends. It's everything. The St. Luke's team, the nurses, the techs, everyone was always so kind and helpful for me, and I'm really thankful for that and appreciative of all their hard work that they put into me and giving me this life.
Histological remission, that's what our ultimate goal is. For Kylie's case, where there's true disease, it means a tremendous amount for us. That's why we do what we do. Specifically, Crohn's disease can cause malnutrition for these patients. And so we really want them to make sure they fulfill their full genetic potential and not necessarily be caught up in her disease and be defined by her disease, just to be concerned about being Kylie.
It's St. Luke's Children's Hospital, ready to help all kids. They're keeping kids healthy, fixing us up, making us feel better, helping kids be the best they can be, because it's about us. The kids! It's St. Luke's Children's Hospital!
St. Luke's Children's Hospital is helping kids with everything, from routine checkups to specialized care.
It's here! It's great! Yeah!
Learn what makes you unique with no-cost genetic screening through DNA Answers, a community health research program available through St. Luke's. Learn how your DNA impacts your health and if you are at risk for certain cancers and hereditary high cholesterol, a cause of heart disease. Gaining a better understanding of your genetic health risks can help you and your doctor personalize your care for a healthier future. Health insurance is not required to participate. Learn more at DNAanswers.org.
Welcome back to St. Luke's Health Now. I'm your host, Ashley Russo. We've had an engaging conversation about pediatric specialties available at St. Luke's University Health Network, thanks to our amazing panelists. Thank you both for being here. Now we've got some questions from our audience. Are you ready?
Yeah.
Dr. Prasad, this question is for you. My grandson was born prematurely and diagnosed with a hernia. How does this happen at childbirth, and what is involved in the surgical repair? You said it's pretty common.
Yes, hernias are very common in infants and children. Many people are surprised by that, and a question that I frequently get is, how did this happen? What did they do? But as opposed to hernias often in adults, which are due to a muscle strain or tear, hernias in children, almost all of them are congenital, meaning they're born with it. And we all, particularly with a growing hernia, we have a canal called the inguinal canal that's open and usually closes by birth. But in some patients, especially premature babies, this canal does not close, resulting in a hernia. After birth, the canal will not close on its own, so it's something that always requires surgery, and it's something that's relatively urgent that I will schedule soon after a visit.
All right, so necessary, but of course, a little bit nerve-wracking.
Of course. Again, it's the parents, and in this case, the grandparents' baby. And they're always surprised that their baby needs surgery. And it's very common and natural to have anxiety about it.
Of course. Dr. Balco, this is for you. My child doesn't seem to have the same appetite she used to have and has turned into a finicky eater. I think we've all gone through that. How do I know if this is the start of a gastrointestinal problem, and at what point should I be concerned? Boy, this happens a lot throughout childhood in my experience.
Right. So I think it's not necessarily abnormal. And what we talked about earlier is that eating habits through childhood will change. Just their physiologic needs will change, and so will their habits. So it's not uncommon for patients, especially after, the first 2 years, to really cut down on what they're eating. I think as long as the child is continuing to be offered different foods, it's really important that they continue to be offered as opposed to just giving them the same thing over and over again. I also feel that looking at their growth parameters, looking at their height and their weight, is also very important, because many times the thought process may be that, I don't think they're eating enough, but if they're growing appropriately on their growth curve, then they're obviously eating enough.
How important is the portion size to consider? Because often we think a whole sandwich is what a 4-year-old should be eating, but really in fact they need a quarter of that, right?
Right. So, portion sizes, that's a whole other issue. The obesity is an epidemic in the United States. So I feel portion sizes definitely do play a role, but I think that, looking at what they're eating, looking at their growth, looking at their energy level, and making sure they're not tired, all these things will play a critical role in terms of determining whether or not that's normal. And also partnering with their primary care physician, they can also kind of give us the idea. And many times I'll even ask, parents who have an innate sense of, do you think they're eating enough? And, for the most part, I think they're pretty spot on.
Yeah, and I like how you said, keep introducing variety. All right, Dr. Prasad, this question is for you. With all of the advances in medicine, can most children who need surgical care for common pediatric issues come home the same day, or do they need to stay overnight? That's a great question, because we do hear a lot about adult surgeries that are one-day procedures.
The short answer is yes, especially the elective things that are scheduled. Those patients can almost always go home. Even with more urgent or emergent situations like appendicitis, which we talked about earlier, many of those patients, if they have early appendicitis and have surgery early in the day, which is most often the case, they can go home the same day. It's those patients that have a more advanced condition or something that requires further treatment, like further antibiotics. Those are the ones that have to stay overnight or for a couple of days.
And how has that played a role in parents' comfort level?
It's really great at St. Luke's. With the facilities that are very new, they're very child-friendly and family-friendly. Each room on the pediatrics floor has a special area for the parents to stay. Both parents can stay. They have their own space with a place to sleep, a TV. So it's geared very nicely for the families.
Excellent. All right, Dr. Blanco, this question is for you. I've heard that diet and genetics can contribute to inflammatory bowel disease. What can be done for children who live with this condition? And we hear this on the rise across the board, but how does it affect children differently, and what role does diet play?
Diet does play a role, and especially for those patients with inflammatory bowel disease, which, that question itself is like the $1 million question. Is it diet? Is it genetics? We don't really know. We think they both play an equal role. And we do know that with westernizing certain undeveloped countries, we do see a rise in terms of the overall incidence in terms of inflammatory bowel disease, meaning that in those patients who were introduced to westernized diet, the fast food, these patients tend to have it a little bit more. By far, medical treatment for inflammatory bowel disease continues to be kind of the gold standard. But we are learning that there are certain diets that can kind of help them as well. And depending on what type of disease, especially, for example, like with Crohn's disease, you can use exclusive diet. So there's a therapy called enteral therapy, where we're just feeding them a certain diet, and that in itself is its own treatment, and these children do really well.
Excellent. Thank you so much, both of you, for being here and for easing parents' nerves out there, knowing that St. Luke's Pediatrics and Children's Hospital is there for them. For more information on pediatric specialties and the services offered at St. Luke's University Health Network, please visit their website at sluhn.org or call 1-866-St. Luke's. Thank you for tuning into this special episode. We hope tonight's program leaves you feeling informed, inspired, and most importantly, empowered. I'm Ashley Russo. See you next time on St. Luke's Health Now.